Okay, great. Our next speaker is Theresa Andrasfay, a postdoctoral fellow at USC. She received her doctorate in demography from Princeton. Her research broadly focuses on population health and the social determinants of health and mortality. She's also interested in assessing methodological tools to study health and well-being. Her recent projects have assessed the association between physical functioning and mortality among adults and how this relationship varies by race. And her current research examines occupational stratification as a contributor to inequality in health at older. So again, we'll plan for the talk and questions to go until about 11:45 and then start our break. So please join me in welcoming Theresa.
Let me just share. Can everyone see? All right, I see a thumbs up.
Great.
Thank you. So today I'll be presenting a couple papers under the umbrella of reductions in 2020 US life expectancy due to COVID-19, and really focusing here on the disproportionate impacts on the Black and Latino population. And both of these projects are joint work with Noreen Goldman at Princeton. So the overall motivation for these projects was that we wanted to quantify the disproportionate COVID-19 mortality burden faced by Black and Latino Americans. And so if you think back to last spring of 2020, we didn't really have good data on race and ethnicity in terms of COVID-19 cases or deaths right away. And there was a lot of push for health agencies to report this. And when they did, it became immediately clear that Black and Latino Americans were facing a disproportionate burden of both cases and deaths. But when these data came out, the way that they were being reported by the media was kind of unsatisfactory to us as demographers. You would see a lot of statistics like the Black population in a certain state is X% of the population, but accounts for Y% of the deaths. And that's not really the best way to assess a disparity, because for various reasons, including fertility, mortality, and migration patterns, the Black, white, and Latino populations in the US have quite different age structures. And so with a disease like COVID-19 that has a lot higher mortality with increasing age, we expect an older population to have more deaths. And so if we're seeing that the younger populations in the US have more deaths, that's showing that there's an even bigger disparity once we were to adjust for age. So we decided to do this with a demographic measure to be able to compare across these populations. And we decided to go with period life expectancy. And period life expectancy is, as you may have talked about earlier this week, defined as the expected years of remaining life at age X for a hypothetical cohort that experiences the mortality conditions of a given year for their entire remaining lives. So of course we know that this does not mean that a baby born in 2020 can expect to live the life expectancy we calculate for 2020, because we don't think that the mortality conditions would persist for the rest of that individual's life. But despite this caveat, we still think it's a really good measure to use for this sort of question, because it's a single summary value that kind of encapsulates these age adjustments. And even though it has this sort of odd interpretation, it's still really intuitive for people to understand, because it's measured on the scale of a human lifespan. So there are other alternatives one could use to adjust for age structure, such as a indirect or directly adjusted age distribution applied to all these populations. But then non-demographers would have a really hard time interpreting the magnitude of that number that were to be calculated. So we decided, life expectancy is nice because everyone knows what a year means. And last, this facilitates historical and international comparisons. And as more people have started doing this work, we're also able to compare our estimates to those produced by other researchers. So that's been really nice. So our specific research questions were, what are the estimated impacts of COVID-19 on 2020 life expectancy at birth for the total US population, as well as for the white, Black, and Latino populations? And I'll present some initial projections that we finalized in October of 2020, and these were published in PNAS in February, as Josh mentioned. And then I'll present some updated estimates that we made in April 2021 that are under review right now. So I wanted to talk a little bit about how when we were doing this project, we were really doing demography in real time. And so I want to compare and contrast what you would need to get an accurate estimate of life expectancy and what we were actually able to do. So if you wanted to really just directly calculate 2020 life expectancy, you would need, in general, these two pieces of data. You'd need the population at risk of dying in 2020, so some sort of census estimate for 2020. And you would need counts of deaths from all causes in 2020 for each age and for each racial population that we considered. But of course, at the time, in the middle of 2020, we actually started doing these estimates in June. We didn't have complete death data for the whole year, and we obviously, or not obviously, we could have had an estimate, but we did not have a good estimate of 2020 population yet. So we had to use what we had and make some assumptions. So at the time, we had mid-2019 population estimates from the census. The most recent year that we had mortality rates by age, race, and ethnicity was 2017. So typically there's a 1 to 2 year lag in these mortality rates produced by NCHS, the National Center for Health Statistics. But we did have data that were coming out quite regularly for COVID-19 deaths. There was a big push to make this data available in real time. And so every week, NCHS released these provisional COVID-19 death counts by age, race, and ethnicity. They were not releasing them separately by sex at the time. And so we don't consider sex-specific estimates. And then we had projections of future COVID-19 deaths, which were, of course, imperfect and changing rapidly depending on the knowledge of the pandemic at the time. So to summarize the data sources we used in both of these estimates, we needed some sort of estimate for total COVID-19 deaths in 2020. And for the initial projections, as I mentioned, we finalized these in October 2020, so we still had 3 months of the year where we needed to fill in. At the time, we decided to use projected deaths from the Institute for Health Metrics and Evaluation. And this institute received a lot of criticism early in the pandemic because it was not fitting the data well last spring. They made a series of adjustments to their model, and while it still has flaws, at the time we were doing our estimates, it had been fairly closely tracking the deaths. At the time, they issued 3 different mortality scenarios. The medium scenario, which we considered to be the most likely scenario, projected 321,000 deaths by the end of the year. A higher mortality scenario assumed that governments would not reinstitute stay-at-home measures, for example, and that projected around 348,000 deaths. And then a lower mortality scenario that assumed everyone wore masks all the time when they left their homes, projected 276,000 deaths. In our updated estimates, we were able to look at actual observed COVID-19 deaths that were reported to NCHS for all of 2020. And the total deaths that we had were about 381,000 deaths. So as you can see, the total number of deaths exceeded all 3 of the projections, even the higher mortality scenario. And we also needed racial and ethnic and age distributions for all of these deaths. And so for our initial projections, we didn't know what the deaths for the last 3 months of the year would look like, but we had deaths that had occurred up until the beginning of October. And so we assumed that that distribution would persist for the rest of the year. In our updated estimates, we could directly observe these distributions. And we also needed some sort of absent COVID-19 mortality conditions. And so we used the 2017 life tables, as I mentioned. And in the updated estimates, we were able to use the 2018 life tables. They recently came out. But again, as I mentioned,
just so I have this straight, your paper was published in based on the first column, and now you're going to provide us with updates of your paper using the second column. Is that the idea?
Yes.
Okay.
Yeah, to see how close we were, essentially.
Gotcha. But you use when we read the paper, it'll be based on column 1.
Yes.
And what you present today is you're going to show us both kind of thing.
I'll show you both, yes.
Okay, thank you.
And then for both of these, we use 2019 mid-year population estimates. So getting into the methods here. So as demographers, we have these methods to estimate what we call cause-deleted life tables. And so essentially these are a hypothetical estimation of what you would observe if you were to eliminate one cause of death. Say deaths from drug overdoses, for example. Here we actually have the opposite problem. We have pre-pandemic life tables, which we can consider to be cause-deleted life tables in which COVID-19 has been eliminated. And making some assumptions, we can add the COVID-19 deaths back in and recover the all-cause life tables for 2020. And so this is a series of formulas for the life table that treat the ratio of all-cause deaths to all-cause plus COVID-19 to modify the life table and increase mortality according to that ratio. Let's see, is there a question in the chat? And so the assumptions we needed to make here, as I mentioned, were that in the absence of COVID-19, mortality conditions in 2020 would be equivalent to the most recent pre-pandemic mortality that we could measure. We had to assume that the cumulative total numbers of COVID-19 deaths under each of the scenarios we considered would have the same age and racial and ethnic distributions as the observed deaths. And the big assumption here that we had to make was that individuals who did not die of COVID-19 in 2020 were subject to the pre-pandemic mortality conditions. So what this meant in practice was that there was no reduction in other rates due to COVID-19 when we estimated these deaths, but we also can't really incorporate excess mortality from causes other than COVID-19. This will be possible soon, and I know people are working on this, but at the time, to be able to do it separately by race and ethnicity, it was not possible.
Can you just explain a tiny bit more the second assumption?
Right. So the second assumption here was that in October, we had the race and ethnicity for deaths that had occurred through October. But in terms of the projections through December, we only had one number of how many deaths would occur. And so we needed to assume an age distribution and a race and ethnicity distribution of those deaths. So we basically assumed that deaths that had not yet occurred would look demographically like those that had already occurred.
Great. So it's kind of this filling up the year extrapolation. And I guess the third wave we didn't know about, probably at the time even when you started, you didn't know about. And so it's going to differ in some ways, but maybe you'll even show us if it did a little bit. Yeah.
Yes. And we didn't know how it would differ. So this was sort of, and I will say that we started these projections in June, and the ones that ultimately got published were finalized in October. But from June to October, every time we updated it, this assumption had been holding, that the age and racial and ethnic distribution hadn't changed all that much in those intermediate updates. But it did actually change quite a bit, as I'll show you with the final or the third wave in 2020. So getting into the results here, these are our main results, and I'm presenting them from the medium scenario. And so in the orange here, we have the absent COVID-19 scenario on the right, and in the blue, the estimated 2020 under this medium scenario. And what you can see here, without even looking at the numbers, is that the magnitude of the reduction really differed by race and ethnicity. So for the total population, we estimated a reduction of about 1.13 years. For the Latino population, about 3 years. For the white population, 0.68 years, and the Black population, 2.1 years. So this implied that the magnitude of the reduction was about 3 times for the Black population, and 4 times for the for the Latino population relative to the white population. So how did we do? As you recall, the medium scenario had way undershot the total number of deaths. There were about 380,000 deaths that we put into our updated estimates. And that's reflected in the magnitudes we estimate. But before looking at the numbers, if you just sort of look at the general patterns here, you can see that in both sets of estimates, we come to the same conclusion that the estimated reductions in life expectancy were really disproportionately among the Black and Latino populations. So we do still see racial and ethnic disparities. They're not quite as large. For the total population here, our impact is about 0.2 years larger than we initially estimated. For the Latino population, it's quite similar. The white population is also notably larger in this updated estimate, and the Black population is a little bit smaller. And the reason we see this is because the third wave really moved to Midwest and mountain states that were disproportionately white. And so we were getting more white deaths than we thought we would have with our extrapolation method. And this is a case here where the disparities narrowed a little bit, but it's not really good news because it meant that everyone was getting worse, not that the disproportionately impacted groups were improving. And so, like I said previously, we estimated 3 to 4 times the impacts for Black and Latino populations, and now we estimate 2 to 3 times, which is still a huge disparity. So let me put these life expectancy declines in the historical perspective here. Here we're showing the past 40 years of life expectancy for each of these groups. And what you can see here is that for the total population, life expectancy has pretty steadily been increasing over this time. There have been transient reductions, but they have been relatively small in magnitude. But even though they were small in magnitude, this was considered a really big deal because historically, in modern times, life expectancy has increased. And so a reduction that's detectable is a really big deal. And as you can see that the reduction estimated due to COVID-19 is huge in relative terms. And not only is it huge in relative terms, it's really unequal. So the Latino population here, you can see in blue, has consistently had higher life expectancy than the white and total population. And there are many theories for this. This is typically called the Hispanic or Latino epidemiological paradox. That it's a paradox because this population has better mortality despite having lower on average socioeconomic status. But that higher life expectancy is quite diminished in 2020. And then on the other hand, you see that Black life expectancy has consistently been lower than white life expectancy, but that gap has been narrowing and it has been improving over this time, but it's experiencing a steep reduction in 2020. And I know you saw Elizabeth Wrigley-Field's paper earlier this week, and she makes that excellent point that even in the context of a pandemic with a huge mortality impact, white life expectancy in 2020 is still higher than Black life expectancy has ever been. So that's, a really disconcerting finding. And so as I mentioned here, we also estimated these disparities in life expectancy at birth. And as you can see, this Latino advantage relative to whites has consistently been increasing, but it's nearly eliminated in 2020. And the Black disadvantage, while it's been narrowing, is going to increase again, we estimate by about 20%. So why were there larger effects for the Black and Latino populations? So first, I'll give you a demographic explanation. So life expectancy is a combination of both mortality rates, but it also really depends on the ages at which these mortality rates increase. So these populations experienced greater mortality increases due to COVID-19 at all ages across the age spectrum. But the ages that experienced substantial increases in mortality were on average younger for the Black and Latino populations. And so if you think of life expectancy, a death at a younger age makes a bigger impact on life expectancy because it's more foregone years of potential life than a death at an older age. And so one way we can see this is with reductions in temporary life expectancy. And I will go through that here. So this did not make it into the paper because we wanted to make this paper kind of accessible to people in other disciplines. But I'm excited to share it here with an audience of demographers. So temporary life expectancy is this concept of expected number of years lived between ages X and X plus N among those alive at age X. So for example, life expectancy, temporary life expectancy between ages 40 and 50, that's a 10-year age span. And if there were no mortality during this time, you would expect to live 10 years during this time period. But in reality, this is more like 9.9 years due to premature mortality. So one thing we can do is estimate how much COVID-19 in our hypothetical life tables impacted temporary life expectancy at each of these ages for each of these demographic groups. So here I'm just showing you the results for the total population. And so you can see the percent change in temporary life expectancy due to COVID-19. And as you can see, this is about 0 up until we get to the age 50 band. Not much years of life were lost up until around age 50. But as we can see that more and more years of life are lost as we get to the older ages, reflective of the fact that older adults had a much higher likelihood of dying had they contracted COVID-19. So this is the result for the total population. But here we break it down by race and ethnicity. And here you can see that within each band, so the gray is the white population, the orange is the Black population, and the blue is the Latino population. So within each of these age groups, you see that the orange and blue bars are more negative than the gray bars, indicating that at each age group, the Black and Latino populations reduced more of their years of life lived within each of these age bands. And another thing you can see is that for the white population, you can't really see any impact at all up until age 50, but you can actually detect these reductions for the Black and Latino populations beginning at age 30. So that's reflective of the fact that these groups are experiencing non-negligible mortality reductions in these quote unquote prime working age years. So that's the demographic kind of mechanical explanation here for the larger impact for these populations. And then we, in the paper, we speculate on the social explanations here. We just have, vital statistics demographic data, so we can't really speak too much to these. But a lot of other researchers are working on this, and they basically come down to 2 categories of explanations. One is higher exposure to COVID-19 through frontline jobs that would especially explain the mortality in the working age population. Reliance on public transportation, crowded multi-generational households, and language barriers regarding mitigation strategies have been put forth. And then on the other hand, there's higher mortality for those infected. And so we know that these populations have higher rates of comorbidities associated with severity and mortality of COVID-19. Lower access to healthcare, especially for undocumented immigrants, has been proposed. We know that these groups tend to see lower resourced providers, all of which can result in poorer quality of care. So as I mentioned, the study is not without limitations. The main thing is that we had to do these calculations with a set of assumptions. And the most consequential one is that individuals who did not die of COVID-19 were subject to pre-pandemic mortality rates. And we acknowledge that these estimates are likely too low. They cannot include excess deaths or indirectly, unattributed COVID-19 deaths because of the way that we did the calculations. And there have been a lot of estimates showing that COVID-19 really only accounted for about 75% of all excess deaths. And then the CDC has done some preliminary estimates that have shown that these excess deaths may be more common among Black individuals. So when we get the final results, we may see that they have a greater life expectancy reduction than we estimated. So I think the next frontier in this sort of work will be looking into what happens in 2021 and beyond. And so I think it's pretty clear that we are going to see a reduction in period life expectancy in 2021. And that's because 2021 has still been quite deadly. There have been over 200,000 COVID-19 deaths, and these deaths have also had racial disparities in them. The remainder of the year will really will really depend on what happens with the vaccine distribution. And so I'm seeing a lot of parallels between the vaccine data and then the case and mortality data last year. So early on with the vaccine rollout, we didn't have race and ethnicity data for who was getting vaccinated. And there was a lot of push to get that so we could know if there were inequities. And again, as soon as we had that data, it became evident that there were inequities in the vaccine rollout. And again, we're seeing very similar estimates where we see in this New York Times piece that the Black share of the vaccinated population is much lower than the population in each state that is Black. It seems like, when we first considered this in our update, it was hard for people to get access. At least now, people who want vaccines can get them, but there's a problem of hesitancy. And then it seems like these vaccines are actually quite effective against the variants, but it remains to be seen what will happen in, hopefully there is no future wave, but we don't know. I think another important thing to consider is the long-term health impacts from those who have recovered from COVID-19. A few recent studies have come out suggesting that even individuals who had what was thought at the time to be relatively minor cases have higher mortality risk months later. And that could be reflected in the mortality data for many years to come. And much more research is needed on that. And then the other thing to consider for continued lower life expectancy is the idea that there were disruptions to medical care, which could result in health impacts for causes of death unrelated to COVID-19, such as detection of cancer at a later stage. And then there could be long-lasting health impacts of the recession. This headline here notes that COVID-19 recession is the most unequal in modern history. And so how equal this recovery is could influence the continued inequities in mortality. So to conclude, regardless of how we measured it with our initial projections or updated better data, we see that COVID-19 has had a huge impact on life expectancy in 2020, especially for Black and Latino Americans. We know that no living cohort is likely to experience a reduction in life expectancy of this magnitude. But nevertheless, we don't think that it's likely that period life expectancy will rebound to pre-pandemic levels immediately. For one, deaths through early April 2021 already imply a 0.6-year reduction in life expectancy. And the deaths that have occurred among Latinos in 2021 imply a reduction of about 1.5 years. And then it remains to be seen what will happen in future years from these other impacts of the pandemic. All right, so thank you very much. This is me at the Berkeley Demography Department when I graduated. I wish I was there today, but maybe in the future. Thank you.
Thank you, Theresa. You tell us more about your graduation. This was an undergrad, right?
Yes, I did a minor in demography in 2014.
Great, loved that picture.
And yeah,
okay.
So thank you to Berkeley for teaching me all these methods.
Thank you so much. So wonderfully presented, and we have lots of time. I think that Elizabeth, Payal is going to lead the discussion. If you've asked a question, you can help Payal by saying call on me in chat, because there's been a lot of discussion. It's going to be hard for her to scroll through. maybe before, while the questions are coming in, I can just ask a general question about, have you guys done any looking at the third wave, and does it change the racial story a little bit, like as especially for whites, where maybe the early deaths were at really old ages for whites in nursing homes, and maybe in the third wave it was younger? That was part of the discussion we were having.
Right. So we know that more deaths in the third wave were white than we had anticipated. I'll have to look. I think they are younger, just because in the early wave, these deaths were really concentrated in nursing homes. But later on, it really spread to a more general population.
Is that a project that you guys are working on, or you're going to leave it to others to write a follow-up?
I think that would be a good follow-up, I think, with final data, once we have, official end of the year statistics on deaths, to be able to really dig into the age composition.
Thanks. One question is about the gender breakdown. Would it make sense to break this down by gender when we get basically the result?
I think that would be something that's a next step. Like I mentioned, it wasn't possible because with these provisional estimates, NCHS has been pretty careful about, it could be due to privacy concerns, but about breaking things down too specifically into small cell sizes. I don't have a good sense of whether the racial disparities would be different by gender. We know that I think the mortality estimates will be worse for men, just because we have seen that men have had higher COVID mortality rates. And perhaps women who have left the workforce in general more than men might have been protected somewhat by that, or especially they may have been disproportionately impacted by job losses, which could result in a lower mortality burden. But I don't really have a good estimate of what that would be like. I know others have worked on that.
Thanks. Another question is the racial gap the same when we look at other life expectancy measures like E50 or E70?
Sorry, can you repeat those again?
Is the racial gap the same when we look at other life expectancy measures like life expectancy at age 50 or 70?
Yes, so in the paper we looked at age 65, and actually the disparity, it still exists at age 65, but it's a little bit smaller. And that's reflective of the fact that a lot of the life expectancy at birth disparity is coming from these working ages, where whites are really not seeing much loss at those working ages, whereas Black and Latino populations are. By age 65, I don't want to say it's equalized because it's not, but it's less unequal at that age.
How is temporary life expectancy change different from increased hazards? Is it the complement?
No, so temporary life expectancy it's not a decomposition, but it's kind of a way to look at life expectancy at certain ages. And it is the result of the hazards. Oh, this is a question. This is a trick question from Josh.
Oh no, I'm just trying to wrap my head around it. Is the idea, I mean, when I look at that big NLX over little LX, I think, oh, that's something about survivorship. So you could have, like, if mortality doubled from 0.1 to 0.2, that's like a doubling of hazards. But in terms of survivorship, it's a change from 0.9 to 0.8. So it doesn't seem, it seems like things change less in survivorship. And it just, when I saw that equation, I haven't thought about it, but it seems like maybe this is kind of the complement of the change in hazards. But if you may not be able to answer this on the fly. I'm just wondering if you could tell us, how do you guys think about this? Is it basically to break down your changes in life expectancy to single age? Is that the goal of it?
Right, it's to break it down into smaller age bands, just so you can see which ages are experiencing these reductions and which are not. So like you said, the hazard happens like the hazard is the log scale, and then life expectancy is
Yeah.
like
No,
the,
I didn't mean to ask a question in any way. I just, and probably that's not a good question to discuss in real
yeah,
time.
I'll have
It's
to wrap my
more
head
like
around it,
imposing.
because like you said, it's not a one for one, like a doubling of the hazard is not a halving of the life expectancy. It's much less than that, because it's happening in the log scale.
Can you talk just a little bit about, I know this paper has made a huge impact and you've like talked in a lot of forums, and could you give us a sense, like for demographers working on COVID and COVID mortality, what some of the things are that have surprised you in terms of the action, or just kind of give us a little description of how the real world interprets this stuff, and your interaction with them, and maybe with the media a little bit?
Yeah, so I think people have not a great sense of life expectancy, and they tend to get it wrong in two ways. So the first is that people think that we're estimating cohort life expectancy, and they think there's no chance that a baby born today is going to experience a year lower life expectancy due to COVID-19. So that's not what we're doing, and they're interpreting that wrong. But then another way I think people, maybe they get it wrong, or maybe they just willfully choose to misinterpret it, is that they believe that the average age of death in 2020 has decreased by a year, but they think that's not a big deal. That they believe the magnitude, but they don't believe it's a big problem. And I think that's, a lot of people have thought, why are we locking down our society to prevent an 80-year-old from dying a year earlier? And so I've tried to explain here that that's not exactly what it is, and that the fact that we're seeing such a big reduction is because a lot of people lost no life expectancy, essentially. And so if you're saying 3 years, it's because some people lost many, many years off their life expectancy. I think it's important because I know some people are working on average years of life lost among those who died, and that's another important way to describe it. That's more intuitive at the individual level.
Yeah, I mean, earlier in the week we had Jen Dowd come and talk about some of the almost willful misinterpretations of things, and people come at this from different angles, and there's no right answer about, is it severe or is it not severe? Of course, it does depend on one's perspective, and I don't think there's one right answer. To me, what was most striking was the fact that we knew that that there was disproportionate mortality among Blacks and Hispanics, but your results, at least as of October, suggest that there's quite a small impact on whites. And so maybe it also explains a little bit of the response. The majority of the country is white, and so kind of the inequality of the outcome is not just in the intense impact on Blacks and Latinos, but on the, at that time, objectively small, relatively small impact on the majority. More questions?
There's another question. Did you look at Asian or Native American populations?
We were not able to. I wish we could, because there's definitely evidence that the Native American population is being disproportionately impacted. This was mainly due to the fact that we weren't able to directly calculate the life table, so we needed to take what NCHS had published and then kind of add in these COVID deaths. And they, for whatever reason, don't publish separate life tables for the Asian and Native American populations. I wish they did, because we would have easily been able to produce these estimates.
I think that's
just an advertisement for the CDC data. I mean, it has the problem that it's only the reported COVID deaths, although they're doing estimates of excess death, but there's a lot of tabular data that they don't do every single cell. Like they don't do age by race, by place, by sex in one cell, but they publish the marginals, or by county even, of a lot of these things. And you can use a lot of the methods we've discussed in this workshop, like you saw Elizabeth Berkeley Field apply, or that Theresa's applying here, or even that Carl Schmertmann just applied to get at things with the CDC data. It's really rich, and there's a lot there, and it's very hard to find oftentimes. But for example, Serge and I use like the counties, get the county by week by race totals that they were publishing. They didn't give age structure, but so there's a lot of information there for a lot of these questions, and it just requires some creativity to use. And I think Theresa also just gave us a model of how you can make your assumptions, state them super clearly, and you don't have to be afraid of making assumptions if you state them clearly.
I think that's all the questions that are in chat. I don't know if other people want to jump in.
I think we're just right on time. Let's thank Theresa for a wonderful presentation, a wonderful, what would we say, icing on the cake of our week. Thanks so much, Theresa. Please turn off your mute and turn on your camera if you can, so that Theresa can see our faces.
I'll check about.
Let's thank her. Wonderful.
Thank you for having me.
Oh, it's just delighted. Thanks for taking the extra time and preparing a special presentation for us. And I think, you know, everybody here is looking for research topics, so they're like happy that to get all these things from you. So thanks so much, Theresa. Maybe we'll see you in a future formal demography workshop. We hope so. Okay, so we're now